Hi everyone, my name is Anel Alfaro, and I'll be presenting the RN to BSN Midwestern State University Capstone's project. My project title is Implementation of the Richmond-Agitation Sedation Scale in ICU ventilated patients. Objectives include evaluating the effectiveness of RAS as a sedation protocol, assessing the impact of RAS on patient comfort, literature review relating to RAS implementation, analyzing clinical outcomes related to RAS-based protocol, identifying barriers to implementation of RAS-based protocol, and determining the educational needs for successful RAS protocol implementation. My pick-up question is, in adult patients on mechanical ventilation, how does the use of the Richmond-Agitation Sedation Scale as a standardized sedation protocol compared to no standardized sedation protocol or a non-RAS-based protocol in improving sedation management, patient comfort, and clinical outcomes? Introduction. Mechanical ventilation is a critical component of care for patients with respiratory failure or those undergoing complex surgeries. However, the use of mechanical ventilation often necessitates the administration of sedatives to ensure patient comfort and prevent agitation. Effective sedation management is essential, not only to minimize discomfort, but also to prevent complications such as delirium, prolonged ventilation, unplanned extubation, and ventilator-associated pneumonia. RAS is a widely used, standardized protocol designed to assess and guide sedation levels in critically ill patients, including those on mechanical ventilation. Despite its widespread use, these remains variability in sedation practices across healthcare settings, with some institutions lacking standardized protocols or relying on less structured approaches. This Capstone proposal will explore the effectiveness of utilizing the RAS as a standardized sedation protocol in adult patients on mechanical ventilation. Evaluating the effectiveness of the Richmond-Agitation Sedation Scale as a sedation protocol involves assessing its ability to improve sedation management in mechanically ventilated patients. The RAS scale provides a standardized objective way to assess and monitor sedation levels, ensuring that patients are neither over-sedated nor under-sedated. This evaluation focuses on how accurately RAS guides sedation adjustments compared to traditional non-standardized protocols. Key indicators of effectiveness include the frequency of sedation adjustments made based on RAS scores, the alignment of sedation levels with clinical guidelines, and the reduction in instances of oversedation and undersedation. A successful RAS protocol should result in more consistent sedation management, reducing variability between patients and across different healthcare providers. Additionally, the use of RAS is expected to improve patient comfort and safety by ensuring that sedation is tailored to the individual need of each patient, minimizing the risk of complications such as delirium, accidental extubation, or prolonged mechanical ventilation. By providing clear, measurable outcomes, this evaluation will determine whether RAS can enhance sedation practices and ultimately lead to better clinical outcomes in the ICU. Assessing the impact of the Richmond-Agitation Sedation Scale on patient comfort focuses on how the use of this standardized sedation protocol influences the level of comfort experienced by mechanical ventilated patients in the ICU. RAS is designed to assess both sedation depth and agitation, which directly impact patient comfort by minimizing pain, anxiety, and distress during mechanical ventilation. By using RAS to regularly evaluate and adjust sedation levels, clinicians can more effectively tailor sedation to the individual need of each patient, ensuring they are not excessively sedated, which can cause drowsiness and prolonged recovery, nor insufficiently sedated, which can lead to discomfort, anxiety, and agitation. The use of RAS promotes a balanced sedation strategy that enhances patients' comfort by reducing feelings of unease or restlessness associated with mechanical ventilation. This evaluation examines patient-reported outcomes such as pain and comfort scores, as well as observational data on sedation-related behaviors. Ultimately, the goal is to determine whether RAS-based sedation results in a more comfortable ICU experience for patients, potentially improving overall satisfaction, reducing the incidence of sedation-related complications, and supporting quicker recovery and extubation. The Richmond-Agitation sedation scale is commonly used designed to assess sedation levels and guide sedative medication titration in critical ill patients. Research supports that the use of standardized sedation protocol like RAS to improve the consistency and quality of sedation management. A retrospective cross-sectional study by Caraway led to the conclusion that the implementation of the mandated RAS score entry limits oversedation of ventilated patients, thereby reducing the number of mechanical ventilation days in the ICU. Sufficient evidence suggests that the mandated RAS entry also reduces the length of stay in the ICU. A randomized clinical trial conducted by Rashidi, where sedation and agitation levels were managed by the RAS as soon as ICU patients were anxious and agitated, compared to patients who were assessed every 6 hours for anxiety and agitation. The results showed that RAS protocol can be very effective in optimizing the use of sedatives in the ICU. In a single-blind clinical trial conducted by Tehran, 79 traumatic patients in the ICU were randomly assigned to the intervention and control group where sedation was achieved using the RAS protocol. Patients who had the RAS protocol implemented had decreased length of mechanical ventilation and ICU stays and lower cost. Analyzing the clinical outcomes related to the implementation of the Richmond-Agitation sedation scale-based sedation protocol involves evaluating the broader impact of standardized sedation on key ICU patient outcomes, including the length of stay, time to extubate, incidence and complications, and overall recovery. RAS, by providing a reliable and consistent approach to managing sedation levels, aims to optimize patient care by ensuring that sedation is neither excessive nor insufficient, thereby minimizing adverse effects that can prolong recovery. For instance, the appropriate use of RAS is expected to reduce the length of time patients remain on mechanical ventilation, as sedation is more finely tuned to the needs of the individual, allowing for quicker weaning and extubation. Additionally, RAS-guided sedation may reduce the incidence of ICU-related complications such as ventilator-associated pneumonia, delirium, or accidental extubation, which are often linked to improper sedation practices. By maintaining optimal sedation levels, the protocol may also shorten ICU stays and facilitate faster recovery, ultimately improving patient outcomes and reducing healthcare costs. Furthermore, this analysis aims to compare clinical outcomes in patients treated with a RAS-based sedation protocol against those managed with non-standardized or traditional sedation protocols, providing evidence of the benefit of a structured, evidence-based approach to sedation management in the critical care setting. Identifying barriers to the implementation of the Richmond-Agitation sedation scale-based protocol in the ICU involves recognizing both systemic and practical challenges that may hinder the successful adoption and sustained use of the protocol. One of the primary barriers is staff resistance to change, especially in institutions where healthcare providers are accustomed to traditional, less standardized sedation practices. Nurses and physicians may initially resist altering their workflow of learning a new skill, particularly if they perceive it as a time-consuming or unnecessary. Lack of training can also be a significant obstacle, as a successful implementation of RAS requires comprehensive education for all ICU staff, including nurses, respiratory therapists, and physicians, to ensure they are familiar with how to accurately assess and adjust sedation based on RAS scores. Resources limitations might further complicate the process, as adequate staff training, continuous monitoring, and adjustments to existing sedation protocols require both time and financial investment. Additionally, variability in clinical practice across different teams or shifts can pose a challenge, especially in busy or understaffed ICUs where consistent adherence to standardized protocol may be difficult to enforce. Conflicting priorities also presents a barrier, as other urgent tasks such as patient resuscitation or acute management of comorbidities may take precedence over implementing new protocols. Lastly, institutional support is critical. If leadership does not prioritize RAS-based sedation or allocate resources for its integration, it may result in poor buy-in from staff and a lack of institutional commitment to the new protocol. Identifying and addressing these barriers through education, clear communication, leadership support, and gradual integration into existing practices will be essential for overcoming obstacles and ensuring the successful implementation of RAS in the ICU. Determining the educational needs for the successful implementation of RAS-based sedation protocol in the ICU is a critical step to ensuring that all staff are equipped with the knowledge and skills necessary to use the tool effectively. First and foremost, staff training on RAS assessment is essential, as clinicians need to be proficient in accurately scoring sedation levels and adjusting care based on those scores. This include not only understanding the scale itself, how to identify different levels of sedation and agitation, but also knowing when and how to adjust sedation medication on interventions accordingly. Additionally, education on the rationale for RAS-based sedation is crucial, as staff must understand the importance of standardized sedation in improving patient comfort, minimizing complications, and optimizing clinical outcomes. Training should emphasize how RAS can help prevent issues such as oversedation, which can lead to prolonged mechanical ventilation, and undersedation, which can cause anxiety, agitation, and increased risk of self-extubation. Interdisciplinary education is also important, as RAS is a tool used across multiple healthcare teams, including nurses, physicians, and respiratory therapists. Ensuring that all team members are aligned in their understanding of the protocol and their roles in implementing it will help to foster collaboration and consistency in patient care. In addition to initial training, ongoing refresher courses and competency assessment should be part of the educational strategy to maintain high level of proficiency and compliance with the protocol over time. Providing easy access to resources such as quick reference guides or online modules will further support staff in incorporating RAS into daily practices, particularly in high-stress ICU environments, where quick decisions are needed. Moreover, creating a culture of feedback and open communication will be vital for addressing any challenges or concerns related to RAS use. Ensuring continuous improvement and reinforcing the protocol's role in patient-centered care. By addressing these educational needs comprehensively, healthcare institutions can lay the foundation for a successful, sustainable RAS-based sedation protocol. In conclusion, the proposed Capstone project aims to evaluate the effectiveness of implementing the Richmond-Agitation sedation scale as a standardized sedation protocol for adult patients on mechanical ventilation. Through a comprehensive review of existing literature, RAS can significantly improve sedation management, enhance patient comfort, reduce the incidence of complications, and optimize overall clinical outcomes. The project will be implemented within the clinical setting with careful attention to educating staff, integrating the protocol into daily practice, and continuously evaluating its impact on sedation practices and patient recovery. While there are challenges such as potential staff resistance and training, the project offers significant opportunity to improve patient care and outcomes in the ICU setting. By incorporating expert feedback, providing ongoing education, and evaluating the impact of RAS implementation, this project not only contributes to the current body of knowledge but also paves the way for sustainable changes in the critical care sedation practices. And that concludes my Capstone's project. Thank you, everyone.